Welcome to our video history project for the American College of Obstetricians and Gynecologists. Today we are interviewing one of ACOG's long-term employees who's been very influential in development of many ACOG projects and programs. She will be retiring in the near future, but we're happy to welcome Ms. Janet Chapin. Jan, thank you for coming.
Thank you for having me.
First, before we start talking about ACOG and all that you've done, let's talk a little bit about you.
Okay.
Where were you born and raised?
I was born in Denver, Colorado. Grew up there, left right after I graduated from high school and went to college in Nebraska.
Where in Nebraska?
Doane College, little tiny, very small, congregationally based school that is about 25 miles south of Lincoln, Nebraska. And I finished there in wrong year. Finished there in 67 and then moved to West Virginia.
And where in West Virginia?
Around Charleston, in that general vicinity. I worked primarily, at first I did a lot of work around community action, because those were the years of the poverty program. And so I worked in the poverty program, and then I worked doing a lot of work with welfare rights and mostly health education. So that's when I decided I should go to nursing school. So I went to nursing school.
And where did you go?
West Virginia Institute of Technology, which I just learned is moving away. They're merging with some other school. And then after that, I worked in a primary care center that was run by the United Mine Workers, running a high blood pressure control program for about 5 years.
Was that the one in Charleston?
No, it was in Cabin Creek, West Virginia.
In Cabin Creek?
Cabin Creek. You know Cabin Creek.
I know Cabin Creek.
And after that, I went to work for the state health department. And I did first I did the statewide high blood pressure program, and then I did the statewide primary care program.
And then when did you join the college?
1985.
And what was
30 years ago.
What was your role when you joined the college?
I was hired to develop two programs. One was adolescent health, and the other was healthcare for underserved women. The college had been doing work in adolescent health, but not consistently up until that time. So they decided to create a formal standing committee on adolescent health care. And at the same time, they created the committee on healthcare for underserved women, because the college felt like the issues of access to care, both for poor women, but also access to specific women's healthcare services, were a problem, and they wanted to address those issues. So that's where it all started.
And when you took over those positions, how did you feel about coming to work for the college?
I came from a state health department. I couldn't believe that the desks matched. You know, it was like, whoa, this is so exciting. It took me a while to get used to it, because I hadn't worked. The state organization is very different than a private nonprofit like the college. And the day after I started working, they sent me to an annual clinical meeting in New Orleans. And this was back at the time when annual clinical meetings were highly funded by drug companies. And I just kind of went, what have I done? But everybody was really wonderful, and everybody was really committed to what we were trying to do. And even though it was just me, there was a lot of support and a lot of interest. And the committees were just terrific, just terrific. Couldn't have been better.
Now at the college, you have far more committees that you're responsible for. What are the other committees you've been responsible for now?
Let's see. What I'm doing right now is all global health work. But in the interim between when I started and now, I also did healthcare economics, and in the healthcare economics committee. We started the CPT coding committee. What else have I done? I think that and global health.
Indian Affairs?
Yeah, oh gosh, right. We worked on, and that committee still exists. I don't do it anymore, but the Committee on American Indian Alaska Natives Women's Health, which still exists and still does work. So it's been a lot. We've started a lot of programs. We did a lot of work around access to care. So we did a lot of work way back when when Bill Clinton was president and his wife was working on healthcare reform, we did a lot of work on healthcare reform then, and actually got the college to take a position that was fairly complicated in terms of universal access, insurance coverage, and Medicaid expansion. We did a lot of work on Medicaid. We did a whole bunch of things to help fellows be able to participate in Medicaid and be able to get reimbursed in a decent way, but also to help the Medicaid program learn how to work better with obstetricians. And then we started a long-acting reversible contraception program. We did a whole bunch of different things.
Of all the projects and programs you worked on, which one have you enjoyed the most?
That's tough.
Assuming you enjoyed all of them.
Yeah, some of them I've enjoyed more than others. I think the two things that I've liked the most, one was working on underserved women, because it was so close to what I cared about. Providing access to women who didn't have access to care, providing access to women who didn't have access to specific services, and the college really stepped out in front in that discussion. They stepped out in front with Congress, they stepped out in front with states. We were really in a leadership role in that situation. And then the second thing I've just loved is the global health. I really loved working on global health. It's been very exciting.
You've obviously been very intimately involved in that.
It started like from the beginning. We had a meeting today with the university-based OBGYN global health programs, and there were probably 50 people in the room. And it was remarkable to see how much global health has grown. And when the meeting started, the moderator began by saying, ACOG used to have an international committee. That international committee met once a year, did a few statements, but really never did any work. And now we've got huge programs that we're doing, both in terms of, we did a strategic plan, and so we're doing educational programs, we're doing skill building programs, we're doing professional association strengthening programs. It's really pretty exciting.
When you joined the college, other than Canada and maybe Jamaica,
that was it.
That was the limit of the college.
Yeah.
Well, Mexico.
Yeah, Mexico came in the 80s, yeah.
That was the limit of the college's international activity.
Yep.
How would you describe it today?
It's all the Western Hemisphere. It's the entire Western Hemisphere. We began with Save the Mothers which was funded by FIGO and UNFPA and the World Bank. And that started in 1997, believe it or not. And that was the program in which we partnered with 4 countries in Central America to work on the reduction of maternal mortality. And we partnered with the OBGYN societies in those countries. And as I'm sure you remember, they then came to us and said, we want to create an ACOG section. We want to be members of ACOG. And so in 2000, we started creating that process. And now we've got all of Central America, Colombia, Chile, Argentina, Peru, Ecuador, and Colombia. I think I said Colombia, but anyway, we've got all of those countries, and we're working right now with Uruguay, who wants to join as well. So there are only 4 countries counting Brazil in South America who are not involved in working on becoming a section of ACOG.
So you would say that the American College of OBGYN
is the American College. Is really the American College, yeah.
But you've also moved out of the America's continent.
We're starting work, and we've started work about 4 years ago in sub-Saharan Africa. A little bit in Asia, but mostly in sub-Saharan Africa, and focused on transferring skills to frontline health workers more than anything else until recently. But part of the way we strategically decided to do that was to work with the OBGYN professional associations in every country where we went. So we've worked in Zambia, Uganda, Malawi, and a little bit in Burma, which got cut off because of the politics. But what we've done in each of those countries is build the professional association's capacity to do either training or policy work or whatever, in fact, they wanted to do. But we're doing training in postpartum hemorrhage work, postpartum hemorrhage treatment in Zambia, surgical skills development in Uganda, because the physicians who go out to become the district medical officers don't have any surgical training at all, and they're the people who do hysterectomies and do cesarean deliveries, and they just are not trained. So we're trying to institute that in the medical school curriculum. And we just started a very large project with Ethiopia because they want to standardize their residency education. The country is investing hugely in medical education, and they just started 9 new residency programs. And those residency programs have nothing in common. They don't have objectives in common. They don't have curricula in common. And we're partnering with the Ethiopian OBGYN Society to develop those materials and develop the structure and create for them a residency accreditation system.
And you've had experience with this?
That's what we did in Central and South America, yeah. And mostly, in Central America, it did grow from the ground up. The 6 Spanish-speaking countries, it doesn't count Belize, because Belize does not have, I think they have 2 OBGYNs, they don't have a residency program. But the 6 Spanish-speaking countries really wanted to join together to create both a residency review process and a certification process. So we've worked with them since 2000 and created that process for them, with them. They do all the work.
How did you overcome the language barrier?
We have a good translator. It's been very interesting because there are individuals who really do not speak much English who are working on this project. But we've found lots of ways to communicate, and my Spanish isn't that good, but I can understand almost everything that's going on. I'm too shy to speak, but because my pronunciation isn't anywhere near correct. But it's interesting, of the group that we started with, at least 3 of them have now become very proficient in English on purpose. I mean, they went and took classes and decided that was what they needed to do. One of them is the current ACOG section chair in Central America. And
how would you rate, on a scale of 1 to 10, the success of these programs?
It's hard to measure, but I think they're extremely successful. What we've been able, because in the U.S., the program that accredits residencies has the power to allow a program to have residents or not have residents. And in Central America, there is no government agency in any country that does that. So what we've been able to do with this group of individuals from each of the OBGYN societies is create an atmosphere that encourages change and improvement. And we can document through, we do a visit, depending on how good the residency program is, between 1 and 5 years after they become accredited. And we can document the changes that they've been able to make. And they range from very simple things like having call rooms, having meal facilities available to the residents, changing the residency hours a little bit so that people get time off. But they've also gone as far as, in Guatemala, for example, now all of the residency programs are affiliated with the university, and they all use the same curricula, they all have the same objectives, and they're funded far better than they were before. So we've seen a lot of change. But it's hard because it's not government connected or formal in that sense.
Well, let's move back then into the U.S. Tell us a little bit about your Indian program that you've been monitoring and overseeing for a number of years.
The college started working with the Indian Health Service of the U.S. government, I think it was probably about 20 years ago. And we've had really 3 programs, but we're down to really 2 now. The first program that no longer exists was basically a volunteer. We had ACOG volunteers who served as locum tenens in Indian facilities when the staff, the regular OBGYN staff wanted to take vacations or wanted to, or left. But now we do 2 primary things. We do a postgraduate course or training in selected IHS regions, and we also visit the hospitals and the health centers in those regions. And it's not like an accreditation process, but it's very much a site visit to provide support and help to them in changing what they need to change. The Indian Health Service has the same kind of problems, actually, that you see in global health. They don't have enough staff. They don't have enough money. Sometimes they have really nice facilities. Sometimes they have terrible facilities. And their ability to mobilize the resources that they need can be really restrictive. They have to build, just like every other hospital or health center in the country, but they don't have the same capability to provide the same kind of services, or often they don't even have the same billing staff as like a regular hospital. So we do site visits the most recent one was in Alaska. There are like 7 facilities in Alaska that 3 of which you can't get to unless you get in a little tiny airplane. We do site visits in the Oklahoma region, which is mostly the Cheyenne Nation. Site visits on the Navajo and the Hopi reservations, and site visits in North and South Dakota. And then there's one other in Upper Wyoming, Montana. And they're all very rural. They're all very, some of them are, like I said, really good facilities. Some of them are really terrible. So, and they don't have enough staff. They don't have enough, money. So our job is to help them.
And how do you help them?
We lobby the Indian Health Service. We give them documentation about what they need and why it meets standards. That, for example, if they don't have ultrasound available in the facilities where they're doing maternity care, we say you have to have ultrasound available, and then they can use that as an argument to go to the Indian Health Service and say we have to have ultrasound available. So buy us an ultrasound. We also do training then with each of the staff in each of those facilities. We do some training when we do the site visit, but more importantly, after the site visit, after we've identified what the training needs are, we go back and we do whatever specifically they really need. We've done a lot of long-acting reversible contraception training. We've done some basic emergency obstetric care training. And those are the biggest things that people have needed and don't have.
You've been at ACOG now almost 30 years.
Yeah, it has been 30 years.
It's a long time.
Yeah.
What have you seen as the biggest change in ACOG?
I believe because medicine has changed so much. I mean, the practice of medicine has changed. The politics of medicine have changed. And the organization has had to change because of that. I think it changes the direction sometimes because there's a lot more emphasis on issues around reimbursement, issues around coding, economic issues, which are foremost in the mind of a lot of members. And less emphasis sometimes on some of the social issues, although we've continued to do work around substance abuse, smoking, things that affect patients directly, that have been really important. But I think it's the change in the atmosphere. I mean, it's the change in the whole milieu of American medicine that's made a big impact on the college. Plus, I have to say, when I came to work for the college, money was not an issue. the college had lots of money. It was getting a lot of money. We got a lot of grants to do the work that we did. But that whole business has changed too, because there aren't that many grants available. The college itself is more fiscally careful and limited than it used to be. So I think those are the biggest changes.
If you could develop, say, one program which you've developed that you would like to see greatly expanded, which one would that be?
It would be global health. I just think the world, everything is global now. We've been able to create a we in terms of an ACOG that is global, including South and Central America and Canada, but the responsibility for improving women's health worldwide is huge, and I think we the college can play a very large role in that. We've got lots of people power. We've got lots of brain power. We have a lot of people who want to do this kind of work. This universities program today was just astonishing in terms of the number of universities who are now trying to help develop residency programs, develop, work with associations, do things that will improve women's health in those countries. So I think that would be the place I would put the most energy.
If you could change one thing right now, what would you want to change?
That's a tough one. I suspect that other than internal organizational change, which I think the college has had difficulty adapting to a new world and a new vision. And for example, global health is a tough thing to do right now within the organization because the focus is really not on service to others, it's on taking care of our members. And that would be the thing I would change. There have been really wonderful leaders in the college, both in the executive vice president position like you were, and in the board, who really wanted to see ACOG move in the direction of global health, in the direction of helping women everywhere. And some of that I would like to see more of.
Okay, I want to thank you very much for coming and sharing your views.
Thank you. It's been wonderful.
It's important that we have the views of long-term employees who have seen a lot of transition.
That's really true. Thank you very much. I've enjoyed it a lot.
Thank you for being here.
Thank you.